Welcome back to the Ninja Nerd Podcast. Today we're going to be talking about calcium disorders, hypocalcemia, hypercalcemia. Got two cases for you, and hopefully you learn a lot.
Yeah, I hope so too, man. This is a really cool topic. It's something that I think a lot of the times patients don't really have a lot of symptoms for, and it's more of a lab diagnosis. And you're going to be kind of trying to work up what's the reason why. And I think that's the big goal. And the overarching theme is what's the reason for the low or the high calcium today?
Yeah, and I think just so people also understand that these podcasts are really supposed to be more supplementary. We're making a lot of lectures, whiteboard videos, digital presentations. This is just supposed to be a little extra something for you. If you want to try and review, it's just something that you can have as an extra resource.
Like if you're driving to school or you're driving to your rotation of whatever it may be, I hope and I pray you're not watching a YouTube video as you're driving there.
Yeah, that's a good point.
And so if you have some free time, if you're maybe doing some dishes, you're going on a run, and you just want to learn a little bit more and you like what we do, that's, I think, the time to really kind of benefit from this. And it's just an extra supplementary resource. You guys want notes? We got it. You guys want illustrations? You want videos? We got it. And you want questions? We got it. So go check it out on our website. Oh, yeah, baby.
I don't know if that was the right one in that situation. All right, so let's just go ahead and get right into it here. We have case one. We're trying to figure out the cause of hypocalcemia in this patient.
Yep.
So we have a 45-year-old female presents to the clinic complaining of tingling in her hands and feet, and she also has muscle cramping. Her HPI, the patient reports that her symptoms started approximately 3 weeks ago and have progressively worsened. She mentions episodes of muscle twitching and a sensation of pins and needles around her mouth. She also notices increased fatigue and some difficulty concentrating at work. For her review of systems, she is positive for numbness and tingling in extremities, muscle cramping, and anxiety. Past medical history, she has a chronic kidney disease, stage 3, hypothyroidism, which is well controlled on levothyroxine. Surgical history, she has had a total thyroidectomy 5 years ago for papillary thyroid cancer. That might be a bit of an interesting...
Yeah, I think we found our little smoking gun here.
Yeah,
let's see.
That might jump out at you there.
Yeah.
So again, medications, levothyroxine and calcitriol started 1 year ago. Vitals. Blood pressure is 132/85. Heart rate is 88. Respiratory rate is 14. Temp is 98.6 Fahrenheit. And the O2 sat is 98% on room air. General, she is alert oriented, but she does have a very anxious appearance. For her neurophysical exam, she has a positive Shovstek sign, Trousseau sign, elicited with a blood pressure cuff. Okay. Extremities, there is no edema noted or muscle cramps were noted during the examination. So Zach, based on the above information, what's your differential diagnosis and what makes you really suspicious of hypocalcemia?
So we know that we're dealing with a patient who has hypocalcemia based upon the case. But what I would say is oftentimes calcium, whenever it's low, it can be pretty much asymptomatic. The things that you want to look for is neuromuscular irritability. That's a really, really big one. So for example, if a patient is exhibiting signs of perioral paresthesias, which this one definitely is, she's got like that like numbness or pins and needles around her mouth. That's kind of a perioral paresthesias. The other thing for neuromuscular irritability is they can exhibit Shovstek sign. I would say the likelihood of that is a little bit lower in real world, but on your board, there's like a 99% chance that it'll be there. And that's whenever you tap over like where the facial nerve would be, and they should get like facial muscle contractions.
Yep.
A Trousseau sign, again, something that you'd see highly likely on the boards, but in true clinical reality, not as often. It's basically, as Rob said, whenever they inflate the blood pressure cuff, it gets pretty high, compresses down in the peripheral nerves running through that area, and it starts causing flexion at the wrists. So they get like a carpopedal spasms.
Let's take a quick second. We'll pop up a couple pictures of both of those signs.
Yeah, so as we can see here, this patient has the Shovstek sign, Trousseau sign, and on top of that, they have some perioral paresthesias. I think that that's really kind of telling me that there's a likelihood of hypocalcemia. Another thing with really bad hypocalcemia is if the patient was having EKG, you might pick that up off of an ECG change. For example, they can have a prolonged QT interval. And so that is one last thing that I would also consider. But here's what I would say. Based upon the presentation, my differential when I have a patient with hypocalcemia is to determine, is it PTH dependent or PTH independent? So if the PTH is the problem, and that's the reason why they're having hypocalcemia, I want to think about hypoparathyroidism. That's a really big one. And that could be surgically, whenever you cut out the parathyroid, maybe accidentally or purposefully. Low magnesium levels can also do this. The other thing is the PTH effect really, really low. So pseudo hypoparathyroidism is another one that I would also be on the lookout for. This is a receptor resistance at the PTH receptor. And then I would also think about vitamin D levels. Are they really low? So does the patient have any kind of concern for malnutrition, decreased sun exposure, liver disease, chronic kidney disease? Those are things that put a patient having high risk of vitamin D deficiencies. And the last thing I was thinking about calcium sequestration. So it's basically whenever you have a patient who has a really high level of like phosphates or citrates or fatty acids that accumulate in the bloodstream, and they bind to the calcium and they reduce the free calcium. So you can see that. I'd say that's more acute, like in rhabdomyolysis, potentially tumor lysis syndrome. Maybe you could even see this in excessive blood transfusions or pancreatitis. I'd say the most common cause of calcium sequestration that we see chronically, though, is CKD, because they have chronically elevated levels of phosphate.
Which she has.
She does, yeah. And so
That's a big
that
one.
begs the question, when you look at this patient's history, what really suggests the likelihood here? I see a history of a thyroidectomy. And when I see that, I get concerned, did they potentially take accidentally a piece of the parathyroid? And is there some degree of hypoparathyroidism?
Yep.
The other thing I want to also watch out for is she does have chronic kidney disease, stage 3. I didn't look at any of her labs yet and see if her phosphate levels are really elevated, if her active vitamin D levels are really, really low. And also in patients who have CKD, what's interesting is their PTH levels are often high. And so what I'll look for is I'll look at the labs and I'll help that utilize that to determine, is it hypoparathyroidism from the surgical procedure, low magnesium, or does this patient potentially have some type of what we call secondary hyperparathyroidism? And so right off the get-go, I have the thought of 3 differentials. I'm thinking, is it potentially hypoparathyroidism? Second, is it potentially a secondary hyperparathyroidism in the setting of CKD? So that's what I would say is my likelihood here.
If we go ahead and get labs and imaging, what would you get for this patient that would be best to try and rule out those differentials?
That's a really good question. So I would start off, first off, calcium, obviously you're going to get that from potentially like a renal function panel, or if you just order a calcium off of like a BMP, CMP, you get it back. It comes back less than 8.5. That's generally like less than 8.5 milligrams per DL. That's concerning. Problem is though, is right away, if I get that calcium back, that's total calcium. That's ionized and calcium that's bound to albumin. I got to make sure it's real. So I always say first thing is when you get the calcium and it's low, make sure. Check an ionized calcium if you're inpatient. Check the calcium correction for albumin if you're outpatient. That's super important. If you check it and the ionized calcium or the corrected calcium come back normal, it's not real. Stop your workup. Don't do anything further. It's pseudo hypocalcemia. We can see this in diseases that have lower albumin levels. And so you have less albumin, less calcium bound to the albumin, your total calcium comes down, but it's not real. If I check it and the ionized low and the corrected calcium is low, then it's real. This has nothing to do with albumin. This is truly the free calcium is low. In that scenario, I get a PTH because I need to know, is it PTH dependent or PTH independent? So I get a PTH, and from there, that would help me out a lot. I would also get a magnesium level. I would get a phosphate level, and then I would also check the vitamin D. I would check the active, which is the 125 dihydroxyvitamin D, and then the inactive, the 25 hydroxyvitamin D. From that, I would be able to, I'd say, get most of my answers of what I really think the underlying causes of this hypocalcemia. So recheck the ionized, corrected calcium, PTH, the 2 forms of vitamin D, a phosphate, and a magnesium level will get you pretty much most of what you need for the workup.
How about imaging? Is there anything in particular you would jump toward?
You could do imaging. I would say the imaging would be best if you really want to take a look at the actual neck. And so if you want to go ahead and do like an ultrasound of the neck, that could be potentially helpful.
Okay.
Especially if you're concerned for something in that potential region that could have caused this. So something near the parathyroids. But I would say otherwise, not too much. I don't think I'm going to
Lab
need
work
too
would be a
much.
little bit more useful.
I think the labs are going to be the big answer.
All right, so we do get some results back. I'm going to go ahead and list these for you, the actual levels of our patient. The norm is going to be listed next to it, okay? So we have calcium is 7.2, phosphate 5, magnesium 1.8, the parathyroid hormone undetectable, 25 hydroxyvitamin D 35, and the 125 dihydroxyvitamin D is low. Imaging findings, we do get a neck ultrasound. There is no residual thyroid tissue or parathyroid tissue visible. This suggests possible surgical removal or atrophy.
Oh, baby.
So there we have it. So now, given the H&P, Zach, the labs, the imaging? Go ahead and give us your diagnosis.
So I think that we've got our answer. So we got the calcium, it's low. And in this particular situation, I would urge the people viewing this, if you're ordering them, get the ionized, get the corrected calcium up from albumin. If it did come back low, it's still real. In this case, we're going to assume that that happened. You get all the other labs which we requested. So the first one I look at is the PTH. So if the PTH is undetectable, I'm going to consider that low.
Yep.
If it's low, I automatically know that it's hypoparathyroidism, and I've already taken off the table that it's low vitamin D from vitamin D deficiency. It's unlikely pseudo-hypoparathyroidism. It's unlikely CKD. So those are all off the table, and I'm stuck with hypoparathyroidism. Then I ask the question, is it a surgical issue or is it magnesium issue? I got the magnesium, it's normal, or at least average, I would say, right? So from there, I could say that it's not hypomagnesemia. And then just for completeness sake, I get the 25 hydroxy vitamin D, that's normal. So there's no true vitamin D deficiency, like no malabsorption, no decreased sun exposure, no cirrhosis of any sort. And then the 1,25 dihydroxy vitamin D is low. That could indicate in some patients that it's CKD, but here's the thing. PTH, guess what it does to the kidneys? It tells the kidneys to activate vitamin D. So if you don't have PTH, which is undetectable, are you going to activate vitamin D? No. And so I expect that to be low. It doesn't mean that there's CKD in this particular scenario. And then we get the neck ultrasound. They cut that puppy out. So
Yeah.
we got our answer. It's likely hypoparathyroidism secondary to a thyroidectomy that incidentally or accidentally removed the parathyroids, given their low PTH, their high phosphate, and the average magnesium level. I'd say that kind of gives me my answer.
All right, so let's move into the treatment approach now. So Zach, how do you treat hypocalcemia? What do you do? Just give her a whole bunch of Tums, or bump that calcium straight up?
Essentially, just get some Tums, you'll be good, honey. No, in this scenario, you got to look. You actually could give them some degree of that, right? Because Tums do have the calcium.
Not that easy though.
Yeah, but like I think the biggest thing here is looking at the degree of the calcium and how low it is, and their symptoms. So she's symptomatic. And then on top of that, she also has a calcium that's less than 7.5. If I'm between 7.5 and 8.5, I don't get too nervous and I don't jump like to being aggressive. If it's less than 7.5 or they're symptomatic, I'm going to be a little bit more aggressive. I'll give them IV calcium. So she had one, I think it was 7.2.
Yeah.
And on top of that, she's symptomatic. I'm giving her like an IV calcium gluconate because you don't need a central line for that. If it was higher and then she wasn't symptomatic, I'd just give her oral calcium, like calcium carbonate of sorts, and she'll be okay.
Okay.
But the big thing is that you have to treat her underlying cause, and you have to prevent this, because you could treat it, get it back to normal, but eventually if you don't treat the cause, it's just going to recur back to having hypocalcemia. So I would say for her, she doesn't need any magnesium supplementation because her magnesium's fine, so I'm not going to worry about that. She doesn't have CKD. Her phosphate's high, but again, the high phosphate isn't representative of CKD. It's just because PTH is, I like the term, phosphate trashing hormone. So it's supposed to excrete phosphate into the urine. And so if PTH is low, you're not going to excrete phosphate, so it goes up. So you just have to address the underlying issue here. This patient's problem is that she has low calcium. So what I'm going to do is I'm actually going to give her oral calcium after I give her the IV calcium, and then I'm going to give her vitamin D.
But she does have CKD.
She does have CKD, and so that's definitely the case, but I don't think the CKD is driving her underlying hypocalcemia.
Okay.
If that was the case, I would expect her PTH levels to be a lot higher.
Sure.
But in this case, I'm going to give her oral calcium. I'm going to give her some vitamin D, like the calcitriol, and that's going to bump up her calcitriol level, which is low. I'm going to give her more calcium, and that's going to help to increase her calcium. And eventually that will help in this patient.
Okay.
If she doesn't get any better with that, sometimes we can give patients like thiazide diuretics, and that might help a little bit because the kidneys kind of retain more calcium. So I would say IV calcium up front. Then after I've given her the IV calcium to reduce and get rid of a lot of her symptoms, then I would say, okay, let's treat the underlying cause. Let's give her oral calcium, vitamin D going forward, see how she does, see if the calcium comes up. And if it doesn't, then I would add on a thiazide diuretic to retain more calcium. But she doesn't need magnesium. She doesn't need any phosphate binders of any sort. So I wouldn't do anything particularly with that. And that's kind of how I would treat this particular patient. A lot of times people will be like, Zach, why don't you just give her PTH? We don't really do that. We don't give PTH to people. And so in this particular scenario, I wouldn't be giving her any kind of PTH.
All right. Well, pretty straightforward then. So that wraps up this first case. However, prior to moving into case 2, if Zach feels up to it, I would love a quick recap of everything we've talked about, just understanding hypocalcemia, making sure that we understand this concept prior to moving on.
Yeah, that's fine. So what if I was just like, nah?
Yeah. No, we're moving on.
No, in this patient, I would say, again, biggest thing is whenever you see a low calcium, look for the symptoms. I think that's important. See if they have any symptoms of neuromuscular irritability. Get an EKG. So look for a prolonged QT interval. Recheck the calcium with the ionized form. If they're inpatient, calcium correction for albumin if they're outpatient. If it's still low, get a PTH. If you get the PTH and it's low, it's hypoparathyroidism. Look for any history of neck surgeries, get a magnesium level. If the PTH is high, it's PTH independent. So that's a vitamin D deficiency, CKD of sorts, pseudohypoparathyroidism. And that's when I would go ahead and I would say, okay, let me go ahead and check a phosphate level, a vitamin D levels, and see what's going on, and a renal function. From there, I should be able to get a good idea of what's the underlying cause. So for example, if the PTH is high, I would check those things. If the phosphate's high, and on top of that, I also see that their active vitamin D levels are really low, I would think pseudohypoparathyroidism or CKD. Look at their renal function. If it's really, really bad, it's CKD. If it's normal, it's pseudohypoparathyroidism. And if the inactive form, the 25-hydroxy vitamin D is low, it's vitamin D deficiency. Once you've figured out those causes, again, ask yourself the question, is the calcium really low and they're symptomatic? If they are, IV calcium. If they're not symptomatic and it's greater than 7.5, oral calcium. Then treat the underlying cause. Oral calcium vitamin D for most cases, the hypoparathyroidism, the pseudohypoparathyroidism, the secondary hyperparathyroidisms, and if they don't respond, they don't get better, add on a thiazide. Low magnesium, give them magnesium. And if their phosphate levels are really high, only in the scenario of CKD, give them a phosphate binder.
Okay.
Does that help?
It sure does.
All right, good.
All right, so let's move right in then to case 2. We're going to be talking about hypercalcemia. So for this case, we have a 63-year-old male presents to the ED with complaints of fatigue, confusion, and abdominal pain. The patient reports worsening symptoms over the past 2 weeks. He notes increasing constipation, polyuria, and polydipsia. He also mentions a recent unintentional weight loss of 10 pounds within the last month. Review of systems. He is positive for fatigue, confusion, nausea, vomiting, polyuria, polydipsia, and bone pain. Past medical history of hypertension. He is medicated with lisinopril. Vitals. BP is 145/90. Heart rate is 88. Respiratory rate is 16. Temp 98.6. And O2 sat is 97% on room air. We do have the general exam of an elderly male. He appears lethargic, mildly disoriented. Neurologic, he is alert but confused. Abdominal, mildly distended, diffusely tender to palpation, no rebound or guarding present. Musculoskeletal, tenderness on palpation of the lumbar spine. So Zach, based on the above information, all of the things that this patient is presenting with, what's your current differential and what makes you suspicious of hypercalcemia?
So that's a good question. I think whenever you have a patient who has hypercalcemia, it's not always easy to pick up the symptoms. And funny enough, you always learn this thing in school where it's like the stones, bones, groans, thrones, psychiatric overtones. Oftentimes, patients are pretty much asymptomatic. Until the calcium gets greater than 14, you probably don't see too many symptoms. Actually, I would say calcium greater than 12.
Okay.
As the calcium starts climbing up above 12, you may start seeing symptoms. And I'd say the most common one is polyuria. And otherwise, maybe some confusion, but all the other stuff, you don't see it too often. What is interesting is the weight loss, because one of the first things that come to my mind is when a patient has unintentional weight loss is cancer of sorts.
Yeah.
And cancer, hypercalcemia of malignancy is one of the most common causes of patients developing hypercalcemia. So I'm definitely concerned about cancer to some degree. The polyuria and polydipsia is the likely presentation. So that, remember I told you they can have what's called stones, bones, thrones, groans, psychiatric overtones.
Sure.
How we remember that is stones, they can have nephrolithiasis. So you look for like flank pain, maybe some nausea, vomiting, hematuria. I don't really see that here. And no history of like recurrent kidney stones in her history. Next thing is bones. I would look for bone pain. Maybe they've had some kind of history of osteoporosis. Maybe they have had some pathological fractures or osteocystic fibrosa. What I am interested in noting here is that she has I apologize. I'm so sorry. It's a habit.
It's a recurrent theme. It's all good.
I'm so sorry. When you look at the musculoskeletal exam, there's tenderness on palpation of the lumbar spine.
That's one thing that jumped out at me. What's that all about?
I think that he may have a pathological fracture of sorts of the lumbar spine, or there's some type of like cancer that's infiltrating into that part of the spine.
So you would think maybe a bone metastasis.
Could be a bone metastasis, or it could be that this patient has something that's chewing away the bone, like high PTHrP, or multiple myeloma, or lytic lesions of sorts. And that's my thought, is that this is a bone disease as a result of an underlying disease. It could be due to the actual cause, or it could be due to the disease releasing lots of PTHrP, lots of vitamin D, or lots of sometimes even particularly like lytic lesions.
So what's your rundown then? Differentials. What's your list?
So I would say right away with this patient, if he has like the nephrogenic DI, he does not have any type of nephrolithiasis. He also does have, again, a little bit of some bone disease here.
Yeah.
I do see a little bit of the neuropsychiatric disturbances with the confusion as well and the lethargy. I don't have any ECGs to concern me about arrhythmias because they can get some QT changes. But the other thing is I see the groans, and they have constipation and abdominal pain. So you can get that. They can get constipation a lot whenever they have hypercalcemia. So I do see some features, but what really I have for my differential here is it PTH dependent or PTH independent? And so if it's PTH dependent, I'm thinking about hyperparathyroidism. So something wrong with the primary portion of the parathyroid where there's like an adenoma, or something's driving the increased replication of the parathyroid tissue. And we can see that in tertiary hyperparathyroidism, like CKD.
Okay.
The other thing is, could it be high PTHrP, which I see in squamous cell carcinomas, especially of the lung, the breast, the kidneys? Could it be due to high vitamin D, which can be that they're ingesting lots of vitamin D? I don't see that in the patient's history. This suggests an intoxication, but I can see it in diseases like sarcoidosis and Hodgkin's lymphoma. Okay. And then lastly is there's lots of bone turnover, which I have some degree of suspicion for. You can see this with lytic lesions like multiple myeloma, bone metastases, as you brought up.
Okay.
And in patients who are in the ICU, bone like immobilization. So that's so far my thought process, but I have a really high degree of suspicion for hypercalcemia malignancy. And so I'm thinking right away, is this multiple myeloma, lytic lesions from bone metastasis? Is this squamous cell carcinoma, or is it like lymphoma? And so that's what's already starting to go through my mind.
Okay, so you've got some differentials. So now let's move into the diagnostic approach. We have to figure out what labs are appropriate for this patient, what imaging is appropriate based upon those findings.
Yeah, so right away, I would check like a complete renal function panel and just get like from that either a BMP, CMP, a complete renal function panel, just to get your calcium levels. It's going to be the total calcium. If it's greater than 10.5, again, remember, always right away, check an ionized calcium, check a corrected calcium for albumin, just to make sure that it's not pseudo hypercalcemia. So if I checked the corrected calcium or checked the ionized and it was normal, it's not real. Stop your workup. Don't even do anything further. Look for what else is going on with this patient. If the corrected calcium comes back high or the ionized calcium comes back high, this is real, and I would check a PTH. If the PTH comes back high, it's a hyperparathyroidism. And then you just have to figure out, is it primary or is it tertiary? From there, I would get a urine calcium and I would get a phosphate level. And I would also look at their renal function. If from that would definitely give me an idea if this is primary or tertiary. And it would also help me to where a lot of the times for your exams, guys, you can get tested on what's called FHH. So familial hypocalciuric hypercalcemia. So I would get the urine calcium because it really helps out with that for the exam. Then from there, if the PTH is not high and it's low, then I think about the other causes. I would check a PTHrP to rule out malignancy. I would check a vitamin D level to rule out like potentially sarcoidosis and lymphoma. And I would check potentially a skeletal survey along with alkaline phosphatase to look for lytic lesions to suggest multiple myeloma or a bone metastasis of sorts. So that's kind of how I would work this patient up right away.
All right. So we get those lab findings back, and here are the results. Again, we're going to have the norms pop up next to the level that's present. Calcium is elevated. It's at 12.4. Phosphate, low, 2.4. PTH, low or undetectable, indicating suppression due to elevated calcium. PTHrP, elevated. This is suggestive of malignancy as the source of the hypercalcemia. 125 dihydroxyvitamin D, normal. The alkaline phosphatase is normal. We get the imaging back. The skeletal survey indicates no lytic lesions. The chest x-ray or the CT scan, there is mediastinal lymphadenopathy and a right lung mass is present. So we have an idea now, Zach. We know what's going on. Given the labs, given the imaging, what's your diagnosis?
Yeah, so this one's perfectly set up. So I got everything back. Calcium's elevated. If I did correct it, or if I did do the ionized calcium and it came back high, cool, it's real. I checked the PTH, it's low. So that rules out right away the primary and tertiary hyperparathyroidism. I don't even need to go down that part of my pathway.
Right.
If it was high, then I would check that urine calcium and I would check the phosphate. And if the urine calcium was high, I would think tertiary or primary. And then I would look at the phosphate. If the phosphate's high, it's tertiary. If the phosphate's low, it's primary. And then if the urine calcium's low, if it's FHH. But in this case, the PTH is low. So then I'm stuck with high vitamin D, high PTHRP, or high bone turnover. So the next thing I do is I check my PTHRP. Boom, came back elevated.
Yeah.
So then I think about squamous cell carcinomas of the lung, the breast, and the kidneys. My 1,25 dihydroxyvitamin D came back normal. It's probably not sarcoidosis, probably not lymphoma. And then my alkaline phosphatase came back normal along with my skeletal survey. So it's unlikely any elevated bone turnover from multiple myeloma or from bone metastases. But then you gave me the chest x-ray, which sealed the deal and showed me that this person does have a right lung mass, probably likely squamous cell carcinoma.
Yeah, yep.
So I think this is hypercalcemia of malignancy due to squamous cell carcinoma of the lungs, given the low PTH, the elevated PTHRP, the normal vitamin D, the normal alk phos, and the normal skeletal survey.
All right. So we have an idea then about the squamous cell carcinoma. How do we then treat this patient? What's the best approach?
Yeah, so back in the day, we'd say, oh, these patients, they have hypercalcemia malignancy. They're probably dehydrated. Give them about 20 liters of fluid.
Oh, boy.
And these patients can be very, very dehydrated. They can be very, very frankly dehydrated. But oftentimes, you don't need to give that much fluid, but you need to give some fluid. And the reason behind this is, think about it. What was their main complaint? Polyuria and polydipsia, right? And so they're going to be dehydrated because what happens is when the calcium gets high, it shuts down ADH at the kidneys. And so they don't reabsorb any water. They lose a lot of that water into the urine. So they're going to get pretty volume depleted. And so one of the first things I'd like to do is start them off right away in two scenarios. If the calcium is greater than 14 or they're symptomatic. Mm-hmm. So this patient is symptomatic. So I'm going to go ahead and I'm going to start IV fluids. So I'm going to give them a good amount of normal saline. Maybe I'll give them anywhere from 2 to 4 liters of normal saline. What that's going to do is that's going to replace their volume losses, and it's also going to help to clear calcium from the kidneys. Second thing is I need to shut down the bones. I can't let the bones keep chewing up the actual bone. I can't let the osteoclast chew up the bone and liberate the calcium. So then I'll give them calcitonin. Calcitonin has the quickest onset out of all of the osteoclast inhibitors. So I'll give calcitonin, it'll have a quick onset. So after we have the calcitonin that gets that quick onset, its effect's going to kind of linger off. So then we want to bring in a third drug here to be able to kind of continue that long-term control, especially in hypercalcemia malignancy. So that's where I would add in bisphosphonates or denosumab. The decision to do these kind of depends. So if a patient has underlying kidney disease, which this patient does, I'd be a little bit less, pushed to give them a bisphosphonate. Instead, give them denosumab. Denosumab is a little bit safer on the kidneys. Bisphosphonate, it's kind of somewhat contraindicated in kidney disease. But they both have good long-term control. Denosumab, some studies have actually shown that it has a little bit even better effect in hypercalcemia malignancy. So I'd give IV fluids. I'd give the calcitonin. It would get the quick onset, but then I would have to give something continually for long-term control. I'd probably give denosumab over the bisphosphonates.
Just because it'll help this patient with the kidney disease.
Exactly.
Okay.
After I've done that, I keep monitoring. I want to see, is the calcium coming down? Is their symptoms going away? As the calcium starts to come down and I see improvement, the symptoms start to go away, cool. I've done my job. I'm going to move on. I'm going to treat the underlying cause. If they don't get better, the calcium continues to rise, they start to get super symptomatic and it gets really bad, that's when I'll probably hemodialyze these patients. So that's when I would obtain central access and start hemodialysis. If they do improve, okay, cool. We've gotten good control. We've rehydrated them. We've lowered the calcium. We've reduced their symptoms. We've got good long-term control. How are we going to treat the underlying cause? In this patient, they have hypercalcemia malignancy. So the biggest thing is to continue them on the bisphosphonates or the denosumab. In this case, I'd prefer the denosumab. Mm-hmm. And that's going to help to prevent recurrent hypercalcemia. If a patient had primary or tertiary hyperparathyroidism, that's when I would actually go to giving them like some kind of like calcium mimetic, like Senecalcet, or I'd cut the parathyroids out. Yeah. They don't have that, so I don't need to do that. And if they had sarcoidosis or lymphoma, I'd give them corticosteroids. But the best thing for this patient is just to continue them on the bisphosphonates or the denosumab long term. And that's how I would treat this patient.
All right. Beautiful. Well, that was the case 2. Prior to moving on, or I should say prior to concluding this episode, like we did with case 1, let's just do a quick recap of hypercalcemia as a whole?
All right, let's do it. So big thing here, I would say again, when a patient has a high calcium, look for symptoms. If you can find the stones, bones, thrones, groans, psychiatric overtones presentation, cool. If you can't and you get the calcium back and it's greater than 12, be a little bit concerned. Those patients are going to be a little bit more of a severe hypercalcemic. First thing, recheck it. How do you do that? Get an ionized inpatient, correct the calcium outpatient. If it comes back normal, it's not real. Stop your workup. If it comes back high, it's real. Get a PTH. PTH high, primary, tertiary hyperparathyroidism. Get a urinary calcium and a phosphate level and look at the renal function. That should divvy out if it's primary, tertiary, and then the weird one, FHH. If the PTH comes back low, it's not have anything to do with the parathyroid. It's now something else. Usually this is when you get into some of your malignancies. Check in there a PTHRP, a vitamin D, the 125 type, and then also I would check the alkaline phosphatase and get a skeletal survey. From there, PTHRP comes back, it's probably squamous cell carcinoma. Look for lungs, breast, kidney, evaluate those with imaging. If it's a elevated 125 dihydroxyvitamin D, think about sarcoidosis, think potentially about some type of lymphoma. You might have to work that up a little bit more. If those are normal or they're not concerning, then I would do a skeletal survey, especially if they have a history of underlying malignancy and maybe they had metastases from that primary cancer to the bones. Get a skeletal survey, look for lots of lytic lesions. If you find lytic lesions, check the ALK-Phos. Look at their history. If the ALK-Phos is normal, they have hypercalcemia, kidney injury, they have bone pain, they have anemia. This is where I'd use the CRAB criteria and think about multiple myeloma. If the ALK-Phos is super, super elevated and they have an underlying malignancy, I'd be concerned more for the bone metastases. Once you figure that out, you then say, is the patient symptomatic, calcium greater than 14? If it is, IV fluids, hit them with a good amount. On top of that, calcitonin to get them started. If they also have that, throw in a bisphosphonate or denosumab, depending upon renal function. Once you start doing that and you see improvement, you're good. Then you need to treat the underlying cause. You don't see improvement, dialyze. Once you start seeing improvement, figure out what do I have to do to prevent recurrent hypercalcemia. If it is malignancy, continue the bisphosphonate or the denosumab. If it is hyperparathyroidism, cut the parathyroid or give them something to suppress PTH production, like a calcimimetic. And then lastly, if it is sarcoidosis or lymphoma, give them corticosteroids. That's how I would do this one. That's awesome.
Have to give a little applause there. That
Thank you.
was very impressive, very impressive. Well, that's it. That's our episode on calcium disorders. We got hypocalcemia, hypercalcemia. We do hope that it helped. That was a lot of fun.
Yeah, that was a cool one. I actually like this one. It was really good. And I hope that at the end of this, that whenever you kind of listen to this, at the end of it, you'll gain some understanding. You'll gain more of a critical, thinking, systematic approach to how to look at these. And I hope it helps you to become a better student. Hope it helps you become a better doctor, PA, nurse, whatever medical field that you're in. I hope it just betters you. Hope that you guys like this podcast. Hope that you like this video. And love you. Thank you. And as always, until next time.